This is the fellow eye of an elderly bilaterally blind lady, and I planned for a transconjunctival SICS, and things did get a little bloody, if you can say that. So here I am placing my transconjunctival incision. It's already a very superficial incision groove. I check, yes, it's not been dissected properly. So under irrigation, I just increase the depth, and this is a tricky area. You really have to go in the same groove. Yeah. Having done that, you can already see that this is excessively bleeding. However, the beauty of this surgery is it doesn't matter. Let it bleed as much as it wants. It's only going to bleed out. So I'm now going ahead and making my corneoscleral tunnel. I've got the plane, looks good, and as you can see, I'm cutting sideways and backwards. Very important in this is don't inadvertently enter into the chamber. In this case, you will be in a lot of pain. So I'm trying my best. She is very elderly. Block is not exactly great, so I cannot expect her to poor thing must be feeling some pain or discomfort at least. However, she is cooperating as much as possible. There will be the occasional downward movement of the head, can't help it. And look at that bleeding. But it doesn't bother my surgical field as such. So I put in my side put in the enter with the keratome, stain the capsule with trypan blue, and I'm expressing both the trypan blue and the air bubble with 2% HPMC, and it's time to do my rhexis, which has to be big. This is probably a large brown nucleus. I've already done the other eye, and I didn't have so much bleeding in that eye, but just goes to show that not all cases, not all eyes are the same. So completed the rhexis. And I am now opening up the incision. So far so good, everything has gone on well. But now look what happens now. I have done a good hydrodissection. I think the pole has prolapsed. I rotate, yes, that's the nucleus rotating, and this one is tumbling, and this can happen, especially when the globe is too soft. Very difficult to rotate the nucleus out into the AC. So I abandon that procedure, reposition it into the bag, and go for my 2 dialer procedure. And look what happens here. Actually, I'm only catching cortex, not able to go under. So I don't want to forcibly go in, because I have no idea of the integrity of these zonules. This is such an advanced cataract. You have to be very careful. Don't make it worse than it already is. So I just aspirate. You can see the block is not good. So she is obviously little discomfort, but she is so old and she is trying her best to cooperate, and I really appreciate that in her. Again I try and decide, no, this is too blind a procedure. I go to the other pole, and I have got this pole, and again the nucleus is tending to tumble. Sort of got it to rotate, and you can see that tumble there. That can indicate that that side of the bag is probably weak. To be very careful, so I just brought it out, and I am trying to. You can't take out the nucleus when it is half inside the bag and half outside. It's impossible. You have to get it out.
so there's no point in hurrying these steps. I tried to sandwich and tilt it into the AC, partially succeeded, and there it is. I've got it out into the AC. I then use the vectors rather than posterior scleral pressure and bring out the nucleus. Once this nucleus is out, there is some blood that has tracked in, and now the next problem that I have to deal is with that thick cortical sheet which I flip into the AC. These sheets can be so thick. I'm using a lot of aspiration, and that's why you can see that occasional flutter in the AC. I also use the side port to get out the rest of the cortex. Once all the cortex is out, put in some HPMC, and I am putting in my single piece rigid PMMA IOL directly into the bag. And then as I aspirate all the HPMC, and I'm just checking, cleaning up all those. There's a lot of blood, but you just wait and see. It looks bad, and look at the post-op. It's beautiful, it's crystal clear, and there is hardly any SCH